Welcome to my talk of drug-coated balloons and peripheral interventions, and I would like to give you an overview about the current clinical evidence in the SFA and below the knee. And I would like to start a little bit with the history and concept of drug-coated balloons, so the idea is not pretty new. It's based on the results and on the idea that drug-eluting stents have performed very good at the end of the 90s, beginning of the 2000s, and it has been already shown in the cardiology field in 2006, published in the New England Journal, that a drug-coated balloon works perfectly in instant restenosis. So the idea was adapted then to peripherals and firstly published in New England Journal in Circulation in 2008. So the first study is called Thunder and the second one FEMPAP. You will see the study results in a minute. But all the Limus groups have failed in the SFA. So Eurocor and Strides, Eurocor from Cordis and Strides from Abbott, have worked with Limus groups, and they have failed in longer lesions. All the groups which have worked in the SFA with paclitaxel, which we are also using, and all the other companies with drug-coated balloons and peripherals, have succeeded. You know, this silver study is now the commercially available silver PTX drug-eluting stent. The short drug-eluting stents which have been adapted from the heart to below the knee vessels are only useful for short focal lesions, because the main problem here is that they are too short, because they are balloon expandable, they are too short to overstent the longer lesions. So they are in max 38 millimeters long, but they have shown better results compared to normal bare metal stents or normal Cobra balloons. So, as always, like in the heart, it's a problem of niointimal hyperplasia, and as you can see here in this picture, after stenting in this animal model, there's a huge niointimal plasia caused by the smooth muscle cells here after the crosscut. This is after 30 days, and as usual, you start as a company to do some preclinicals. You need to evaluate, is my drug dose, which I have got on the balloon, really working in a proper way? So we measured in pig arteries the drug uptake in the vessel wall with histological cuts after 1 hour, 1 day, 3 days and 9 days with 2 different inflation times. And as you can see here, on the left bar you can see that this is a drug uptake in micromolar per liter. We have got, after 1 minute balloon inflation, which is here the blue bar, a drug uptake of 220 micromolars, but more than a double drug uptake after 2 minutes. So we really recommend to inflate the balloons because they are longer and thicker. To inflate the balloons more than 2 minutes, especially in calcified lesions, instant restenosis, and below the knee, because these are tricky lesions. And a longer balloon inflation definitely guarantees you that more drug is going to be uptaken with our drug coating in the vessel wall. And as you can see here, to answer your question from a minute ago, you can see here after 9 days there's nothing left found in the vessel wall. Everything is uptaken, so the cells have uptaken the drug, and it's a very safe procedure. Secondly, we made an overstretch test after 2 minute balloon inflation. So you put a normal balloon into a pig artery, you overstretch it by 30%, you create an artificial restenosis because the pigs don't have got restenosis normally, and then you measure the area of stenosis, normal balloon versus drug coated, which is the blue one, in the femoral arteries, and as you can see here, the area of stenosis in both cases and the intimal area is significantly lower. And also we've seen the same picture in the iliac.